She had been noticing it for about 8 months. Every morning, when she used the bathroom, there was foam in the toilet bowl, not bubbles that disappeared in seconds. She knew what those looked like. This was a persistent foam, the kind that lingered, that was still there when she flushed. She mentioned it to her daughter once, who told her it was probably just the toilet cleaner. She mentioned it to her pharmacist, who suggested drinking more water. She did not mention it to her doctor because she did not know it was the kind of thing you mentioned to a doctor. It was just foam. She had been watching the slow accumulation of evidence that her kidneys were in trouble for 8 months and had no idea that was what she was seeing. When her labs finally came back, after a routine physical she almost skipped, her GFR was 41. She was in stage 3 chronic kidney disease. She had lost over 40% of her kidney filtration capacity, and the toilet had been telling her for almost a year. What I want to give you today is the knowledge that would have changed what she did in month 1 instead of month 8. Not just what foamy urine means, not just the mechanism behind it, but the complete clinical picture, why it happens, what distinguishes clinically significant foam from the benign kind, what the foam tells you about the specific type of kidney damage occurring, what other signs accompany it, and what to do about it in a sequence that gives the earliest possible intervention window. Because in kidney disease, the window matters more than in almost any other chronic condition. Filtration capacity that is lost does not come back. The nephrons that have been destroyed by chronic proteinuria do not regenerate. Every month of delayed investigation is irreversible. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you are currently noticing foamy urine and you have not mentioned it to your physician, I want to give you the language and the urgency context to do that this week, not at your next annual physical, this week. Subscribe to this channel right now before we go further. I have covered urine color, urine odor, and kidney function extensively in previous videos, and this one completes the picture in a way that brings all of those pieces together. Subscribe now, it is free, and stay with me for the mechanism, because understanding why the foam forms is what makes everything else about this topic make clinical sense. Let me start at the biology of the kidney filter, because the foam is a direct consequence of filter failure, and you cannot interpret the foam without understanding what the filter is supposed to be doing. Your kidneys contain approximately 1 million nephrons each, 2 million total. Each nephron is a functional filtration unit consisting of a glomerulus and a tubule. The glomerulus is a tiny tuft of capillaries surrounded by a specialized capsule. Blood flows into the glomerulus under pressure and is filtered across the glomerular basement membrane, a highly selective barrier that allows water, small molecules, and electrolytes to pass into the tubule while retaining proteins, cells, and large molecules in the blood. The selectivity of this filter is extraordinary. In a healthy kidney, the glomerular basement membrane allows less than 150 milligrams of protein to pass into the urine per day, an amount so small it is essentially undetectable. The tubules recover most of this, and the final urine contains less than 30 milligrams of albumin per gram of creatinine. Healthy urine contains almost no protein. When the glomerular filter is damaged by hypertension grinding against the capillary walls over years, by the metabolic toxicity of chronically elevated blood glucose in diabetes, by autoimmune attack on the basement membrane in conditions like IgA nephropathy or membranous nephropathy, by the amyloid deposits of systemic disease, the selectivity of the filter breaks down. The barrier that normally retains proteins in the blood becomes permeable to them. Albumin, the most abundant protein in blood plasma at approximately 4 grams per deciliter, begins crossing the damaged filter and appearing in the urine. This is proteinuria, and proteinuria is why the urine foams. Albumin and other proteins are surfactants. They reduce surface tension. When protein-containing urine hits the water in the toilet bowl and is agitated by the stream, the reduced surface tension causes the formation of bubbles, the same principle that causes a protein-rich stock to foam when it boils. In urine with normal protein content, the surface tension is high enough that bubbles form briefly and collapse within seconds. In urine with elevated albumin, the surface tension is persistently reduced. Bubbles form easily, and they are stable. They persist because the protein film surrounding each bubble resists rupture. This is the foam that lingers. This is the foam that was in that woman's toilet for 8 months. The persistence test is the most important clinical distinguisher between benign bubbles and pathological foam. Benign bubbles from turbulent urine stream, from toilet cleaner residue, from concentrated morning urine, or from dehydration disappear within 15 to 30 seconds of the urine stream stopping. Pathological foam from proteinuria persists. It is still there after 30 seconds. It is often still there after 60 seconds. It may be visible as a thick, white, stable foam ring around the water surface even after flushing and refilling. If you are not sure whether what you are seeing is benign bubbles or pathological foam, watch it for 30 seconds after you finish urinating. If it is gone, it was likely benign. If it is still there, it warrants investigation. Subscribe to this channel right now, because I am about to tell you exactly what the foam is measuring and why the number it corresponds to is the one most people are never told to track. Subscribe. It is free, and this is the kind of clinical translation I produce every single week. Now let me explain what proteinuria is actually measuring about the kidney's condition, because most people think of protein in the urine as a symptom, something the damaged kidney produces. It is more accurate to think of it as a rate of damage, a continuous measurement of how fast the glomerular filter is being destroyed, and therefore how quickly the kidney is losing its filtration capacity. When albumin leaks through the damaged glomerular basement membrane, it does not simply pass through and leave. As it moves through the tubule, it is partially reabsorbed by tubular cells, a process that overloads the tubular reabsorption machinery when albumin leak is high. Tubular cells exposed to excessive albumin reabsorption undergo a specific stress response. They activate inflammatory pathways, produce pro-fibrotic cytokines, and eventually undergo a transformation called epithelial to mesenchymal transition, in which they change from functional tubular cells into fibroblasts that lay down scar tissue in the kidney interstitium. This process is called tubulointerstitial fibrosis, and it is the final common pathway through which virtually all forms of kidney disease reduce filtration capacity. The proteinuria is not merely a marker of glomerular damage. It is an active driver of tubular destruction. The foam in the toilet is not reporting on damage that has already occurred. It is announcing damage that is actively occurring and accelerating as long as the proteinuria continues. Research published in the New England Journal of Medicine established that the urine albumin to creatinine ratio, the standard clinical measure of proteinuria, is one of the strongest independent predictors of kidney disease progression, cardiovascular mortality, and all-cause mortality in adults with and without diabetes. For every doubling of the albumin to creatinine ratio, the risk of reaching end-stage kidney disease, the point at which dialysis or transplant is required, approximately doubles. This is not a marginal association. It is one of the most consistent dose-response relationships in all of nephrology, and it holds in the range of what is called microalbuminuria, protein levels too low to produce obvious foam, detectable only by laboratory test, as well as in the range of macroalbuminuria that produces the visible foam I have been describing. The clinical implication of this is that visible foam in the urine represents macroalbuminuria, protein excretion at a level that has already passed the microalbuminuric threshold and entered the range where tubulointerstitial fibrosis is actively progressing. The kidney damage is not early. It is established, it is ongoing, and without intervention to slow the proteinuria, it will continue at the rate that the albuminuria level predicts. Now I want to tell you about the conditions most likely to be causing the foamy urine you are seeing, because there are several and they differ significantly in their management. Diabetic nephropathy is the single most common cause of proteinuria and foamy urine in seniors. Chronically elevated blood glucose glycates the proteins of the glomerular basement membrane, thickens the mesangium, the supporting structure between glomerular capillaries, and produces progressive glomerulosclerosis, scarring of the filtration units. The onset of diabetic nephropathy is silent. It begins at the microalbuminuric level, years before visible foam appears. By the time foam is visible in the morning urine, significant glomerular damage has already occurred. The UK-PDS study and multiple subsequent trials established that tight glycemic control and blood pressure management, specifically with ACE inhibitors or angiotensin receptor blockers, can dramatically slow diabetic nephropathy progression, but the window for maximum impact is early. Once GFR is below 60, the rate of progression accelerates and becomes harder to interrupt. Hypertensive nephropathy, kidney damage from chronic elevated blood pressure, is the second most common cause of proteinuria in seniors. Hypertension drives mechanical stress against the glomerular capillary walls, produces endothelial dysfunction in the kidney's microvasculature, and accelerates the glomerulosclerosis that diabetes alone would produce more slowly. Seniors with both diabetes and hypertension, a combination that affects an enormous proportion of the over 65 population, have a synergistic glomerular damage burden that produces proteinuria and foam much earlier and more severely than either condition alone. The most important intervention in hypertensive nephropathy is systolic blood pressure below 130 millimeters of mercury, a target that is stricter than the standard blood pressure goal for patients without kidney disease, and that most hypertensive seniors are not achieving. Before I give you the other causes and the complete action framework, this is the moment to share this video, not for the reasons I usually give. Share it because kidney disease is silent until it is not, and the person in your life who is watching their toilet bowl and dismissing what they see has 8 months or 12 months or 2 years of investigation they could be doing right now instead of waiting. Share this with them. Then come back for the action plan, because the specific tests, the specific language, and the specific timeline are what turn awareness into intervention. AGA nephropathy, inflammation of the glomeruli triggered by immunoglobulin A deposits, is the most common primary glomerular disease worldwide and is significantly underdiagnosed in seniors because it can be clinically silent for years. It presents classically with episodic visible blood in the urine following upper respiratory infections, but in its more indolent form, it presents simply with persistent proteinuria, often with microscopic hematuria and foamy urine. It is diagnosed by kidney biopsy. The reason I include it here is that a senior with foamy urine who does not have diabetes and does not have poorly controlled hypertension should have IgA nephropathy in the differential, and their physician should know to order the urine albumin to creatinine ratio, the complement levels, and the IgA level that point toward this diagnosis before the biopsy conversation begins. Myeloma kidney damage from the light chains produced by multiple myeloma plasma cells, is another cause of proteinuria in seniors that is under-recognized because multiple myeloma itself is underdiagnosed in this population. Light chain proteinuria produces a specific type of foam that does not react on the standard urine dipstick protein test. The dipstick detects albumin specifically, and light chains are not albumin. A senior with foamy urine, a negative urine dipstick protein, normal albumin level on blood tests, and unexplained anemia, bone pain, or fatigue should have serum and urine protein electrophoresis ordered to exclude myeloma kidney. The discrepancy between obvious foam and a negative dipstick is the diagnostic clue. There is also orthostatic proteinuria, a benign condition, most common in younger adults but occasionally seen in seniors, in which protein appears in the urine when upright but not when recumbent. This is the one cause of foamy urine on this list that does not require aggressive investigation. It is identified by collecting 2 urine samples. One first morning void before rising, which will be protein negative, and one collected during the upright day, which will show protein. If both the morning and daytime urine show protein, orthostatic proteinuria is excluded, and the investigation should proceed. Here is what to do in the next 48 hours based on everything you just heard. Today, perform the persistence test on your next morning urine sample. Observe the toilet bowl for 60 seconds after urinating. If foam persists beyond 30 seconds on 3 consecutive mornings, you have a finding that warrants medical investigation. Write down what you see, note the time of day, whether the urine was concentrated or pale, and how long the foam persisted. This is the documentation that makes your physician take the report seriously rather than attributing it to dehydration. This week, call your doctor and use these specific words. I have been noticing persistent foam in my morning urine for several weeks, and I would like a urine albumin to creatinine ratio test, not a standard urinalysis, not a urine dipstick, a urine albumin to creatinine ratio. Say those words by name. This is the test that detects the proteinuria that foamy urine represents. A urine dipstick will miss low-level proteinuria in a significant proportion of cases. The albumin to creatinine ratio will not. At the appointment, also request a complete metabolic panel with creatinine and cystatin C-based GFR estimate, and bring your blood pressure readings from the past month if you have been monitoring at home. The combination of albumin to creatinine ratio, GFR, and blood pressure gives your physician the complete picture of where your kidneys are right now and how fast they are moving in the wrong direction. You now know what the foam is. It is not nothing. It is not the toilet cleaner. It is the physical evidence of albumin crossing a damaged glomerular filter. A filter that is being destroyed by the same albumin that is leaking through it. A filter whose destruction is measurable, whose rate is predictable, and whose progression can be slowed dramatically if the intervention starts now rather than after the next annual physical. Subscribe to this channel if you have not already. My next video covers the complete dietary protocol for slowing glomerular damage progression, the specific dietary changes that reduce proteinuria independent of medication, the protein intake level that protects rather than burdens the damaged kidney, and the blood pressure management approach with the strongest evidence for nephroprotection. Subscribe so it comes directly to you. I am Dr. Edward. The foam is a message. Now you know how to read it. I will see you in the next one.